Hello everyone, I'm Sheila and today we're going to be sharing about what is next after the diagnosis of ALS. This is basically a community-based experience in Indonesia and I have nothing to disclose. All right, to begin with, I would like to quote Orsini and colleagues here. ALS is without doubt a disease of the CNS, which its natural history is one of the darkest in neurology. And I think we all physicians can relate to this statement right here because it is a very complex disease. Okay, so what is next after the diagnosis? Today's presentation basically to discuss about that. After the diagnosis of ALS, there is care. There is ALS care, and we're going to be discussing about daily and advanced, including end-life treatment, to reach the one focus goal, which is to achieve quality of life for the patient. I'm just going to go briefly here for the introduction. We all know that ALS is caused by progressive degeneration of motor neuron, which is resulting in paralytic manifestation. And it's still considered a rare disease. Male is commonly more affected than female, and we can see that it's more commonly found in the 50 to 65 years old age group. Sporadic ALS is much more common than familial, and limb onset type is also much more common. And now I'm going to take you to a brief history of time, which is actually a wonderful book written by the late Stephen Hawking, an ALS patient himself. So in 18th century, Charcot discovered ALS, and in 1939, a famous baseball player from USA acquired ALS, and this actually just brought more awareness to the disease. And then fast forward to 120 years later, since the first discovery of ALS by Charcot, Riluzole was approved by FDA as the first medicine to halt the progression. And then 20 years later, after Riluzole, a second drug was approved by the FDA to slow down the disease progression. As you can see here, I just want to kind of like, show the magnitude that it's been 2 centuries and still the cure is still somewhere in the horizon. So it is up to us, the clinicians, to actually help the patient to be cared for and achieve good quality of life. So after diagnosis, there is care, and this is the overview. And care begins by conveying the right message to the right person at the right time. And I'm just going to be sharing about what the guideline state about what to convey to the patient at time of diagnosis. We can tell them, yes, this is very devastating, but let's discuss reasons for hope. And don't worry, the complications of ALS are treatable. And yes, every attempt will be made to maintain your function, and whatever decision is respected. And yes, I can inform you about support groups, and we can offer contact details. And no, I will not abandon, and you will continue to be cared for. So basically, this is just the first step to care by conveying the right message to the patient. And after that, it is always a teamwork. We cannot work alone in providing care for the ALS patient. It requires MDT or multidisciplinary team to make it an ideal work. This is a great journal from neurology. It's saying that by working together, we can actually improve the quality of life. And it's interesting to see that, as you can see, ALS Association is included in the team with the health workers. So in my opinions, there are so many challenges in ALS care, but I'm just going to highlight 5. ALS is progressive disabling condition, but with relatively normal cognitive function in most cases. And the psychological consequences of knowing the end is near can sometimes cultivate different responses. And we always kind of like do constant adjustment to management because the disease will progress eventually. And there are so many symptoms that challenge the patient's quality of life. And especially in my country where I come from, financial and supportive facilities are quite limited. So basically, we encourage person with ALS or PALS to do routine checkup every 3 months in stable course. And also we can do ALS other scoring for monitoring. So I'm going to start with ALS daily care, the next step after diagnosis here. There are only two highlights, two issues in ALS care, which is nutrition and respiration. The first part is nutrition, and I put here a journal from neurology that nutrition is actually an independent prognostic factor for PALS. And we all know the patient is extremely prone to malnutrition because of, they have feeding problems, loss of appetite, and then shortness of breath, tiredness, in part of the metabolism problems itself. So it is important for us clinicians to do dysphagia screening at each visit. So I put down what to do when an ALS patient comes to our office. We need to assess swallowing problems routinely. We ask them if they choke, coughing during eating, drinking to observe aspiration risk. And then we measure body weight, is their body weight loss more than 10%? And we ask if they are hungry all the time, like they haven't eaten enough food, and whether they're drinking enough. And how about the duration of meal time? Is it now requiring longer than 30 minutes? And then after we do this, we tell the patient to change the food consistency to make it thicker and say no to thin food. And then to also eat high calories diet. And then we educate them about aspiration risk. And if indicated, we try to persuade the patient to use feeding tubes. PEG is definitely more preferable, but we need to be cautious in those patients with forced vital capacity less than 50%. And the second highlight is actually respiration, which I think the most few complication of ALS so far is breathing difficulties. This actually can lead to an emergency situation. I want to stress out that the patients with ALS always constantly under or hypoventilated, which is making them prone to carbon dioxide buildup. So we as physicians, we need to be able to recognize early signs of under or hypoventilated before the actual crisis actually come. So be vigilant of under or hypoventilated early signs such as increased fatigue, sleep disturbance, morning headache, daytime sleepiness, increased yawning or shortness of breath. We need to screen these symptoms at each visit. And after that, to the patients, we measure the baseline forced vital capacity at first visit and always ask for subjective breathing complaints or discomfort. And we ask them for thick secretions. And we work together with rehabilitation specialists for chest physio. And we can teach the patient to do breathing exercise technique at home, like breath-taking technique to strengthen the muscles. And then we tell the patient, we encourage routine vaccination for PALS and to avoid contact with those having, active respiratory tract infection. We can prescribe medications as needed. And we also include respiration in the advanced care plan, including need of assistive ventilation mission in the future. I will be talking about the ACP shortly. So I try to compose one table right here. I try to narrow down all the symptoms most commonly complained by the patients in our group. Most commonly, definitely, is about salivation, constipation, cramps, spasticity, and sleeping problems. And we have various non-pharmacological treatment and then pharmacological approach, whichever available in your country or region. Basically, the medicines here that I put is what we have in Indonesia. So amitriptyline is very good for hypersalivation. And now, in regards to specific therapy, which is riluzole and edaravone, I found a very good journal here. Riluzole is much an older drug approved, and the first drug to halt the disease was Riluzole, and now there's edaravone, which is proven to have less ALS average score decline after 6 months therapy, and I provide some journals here supporting evidence-based medicine in regards to edaravone and slowing the disease progression. And we're going to be move on to the ALS care, which is more advanced care plan, including end-of-life treatment. So what is actually advanced care plan, or ACP? ACP basically is an active discussion process. It is about treatment wanted or not wanted by the patient, and they can change their mind anytime. It's very flexible, can be modified, and there is no right or wrong. And I think ACP is very crucial to prevent confusion in times of emergency or crisis. So it's kind of like a guiding light, you know, in the times of emergency. I put here a table that maybe we can use. This is an example of ACP table, and they can circle the desired treatment, whether they want Riluzole, edaravone, PEG, feeding tube, and IV, including to get tracheostomy. So ACP sometimes linked to end-life treatment, as we all know that the life expectancy for ALS patients is about 2 to 5 years, and it can be longer for those choosing advanced care and in some ALS variants. And we always like to describe to the patient that end of life is like a bear in the winter. When food is sparse and climate is cold, the bear will go to hibernate. So you will sleep more hours and go less hungry. And that actually the process of natural dying in ALS usually a painless process, because sometimes they fear what is it like. So it's actually painless. So pals with good cognitive function still can voice what they want to the medical team, how they would like to hibernate during ACP discussion. And there are those in our experience who choose to decline tracheostomy and wish to hibernate naturally. And we can tell the family that, okay, so he or she will sleep longer, wake up less like the bear, but you will continue feeding, bathing, caring, loving during the waking up hours. Just let the patient to rest, and then avoid asking unnecessary questions like, do you remember me? Do you know who I am? And just ensure adequate hydration at all times. And we can offer hospice care if it is available in your region. And I would like to share a very good quote. This is Loh Ichin's quote. She is a colleague of mine. She's a palliative consultant from Malaysia. She said that near the end of life, time may be short, but they can be one of the happiest and precious moments we have with our loved ones. And how about ALS care in Indonesia? I would just like to share that until this point, there is no established epidemiology data, but we do have around 91 patients in the foundation, and most of them are male. The age range is from 20 years old to 73 years old, and we do have a lot of challenges, but I just put some of it here, like geographical distribution, and then we have limited access to EMG facility, and then limited health coverage. And we conducted a survey in the foundation, and we found that the time required from the first onset to the first EMG examination, not even to diagnosis, just first EMG examination was even more than 12 months or more than 1 year. So despite the limitations, we do have some care availability. We have the multidisciplinary team, we have the medicines for the symptomatic treatments, we have some medical equipments, and then medical procedures are covered by the national health system. But unfortunately, the non-invasive, invasive ventilation, including home care services, are not covered by the national health system. And the good news is we do have community-based group, which is Indonesia ALS Foundation. And I'm going to be sharing about what the Indonesia ALS Foundation have been doing. This foundation was first founded in 2015, and we have published a free care book. It can be downloaded by everyone, not just the patient or the families. It can be downloaded by including physicians. And we made seminars for the medical professionals. We have a WhatsApp group for the patients and their families, and also we conduct routine gathering every 3 months for the families and their caregivers. We like to invite several speakers coming from different specialists. And also the Indonesia ALS Foundation is affiliated with International Alliance of ALS MND. So what is next after the diagnosis of ALS? I put out a chart in summary. So after the diagnosis of ALS, it's definitely ALS care. And ALS care is delivered by multidisciplinary team, including ALS Association and the families. ALS care consists of daily care and advanced care and end-life care, highlighting a nutrition and respiration issue. And the main goal is to manage ALS-related symptoms as well, to provide the best and optimal quality of life for the patients with ALS. I think this chart represents what my presentation is all about. And I'm just sharing about the contact for the Indonesia ALS Foundation. You can reach us by email or website. Any one of you who would like to establish a similar society, please feel free to contact us. We'll be very happy to network and share and discuss together how to help the ALS patients. And we are all sending the warmest wishes from Indonesia ALS Foundation. We wish you all well. Thank you.